Hello, everybody. My name is Mirvat Alasnag. I'm an interventional cardiologist in Jeddah, Saudi Arabia, and I'm here to give you updates on the TCT conference and some of the most relevant late-breaking clinical trials in the intervention space. The first one is the AGENT IDE trial. Now, this is a pivotal randomized trial that compared the safety and efficacy of a drug-coated balloon compared with a conventional balloon angioplasty in patients who had in-stent restenosis. It was a pragmatic design, prospective trial with a superiority design across about 40 U.S. trial sites, and they included about 480 patients. The key inclusion was, as I mentioned, in-stent restenosis with patients who had previously been treated with bare metal stents and were symptomatic, or drug-eluting stents with lesions that were anywhere from in a vessel that was 2 to 4 millimeters, diameter stenosis 50 to 100%, and symptomatic individuals. Exclusion was left main disease, acute ST elevation MI, thrombus, and patients were really randomized 2-to-1 after successful pre-dilatation of the target lesion with either drug-coated balloon versus conventional angioplasty. And the primary endpoint was target lesion failure at 1 year, which was a composite of target lesion revascularization and target vessel myocardial infarction or cardiac death. And they were followed up for in-hospital 6 months, 30 days, 6 months, 1 year, and then annually between 2 and 5 year intervals. Initially they were supposed to have 600 patients, and then the primary analysis was done on 480 patients because it was evidently powered for events, and this was recommended by the TCT board. The mean age was 67, 26% for women, diabetics about 50%, but interestingly, about 77% had multi-vessel disease, and over 50% had stable coronary disease, but 48% had lesions that were 10 to 20 millimeters in length, which means this was quite diffuse, long vessel disease, and multiple stent layers were seen in 43% of the cohort. So this technical success was very high, 90%, and target lesion failure at 1 year occurred in 17.9% of those who got the drug-coated balloon, and in about 28.7% in those with the angioplasty alone. The absolute risk reduction was 10.7, and the NNT was about 10. So overall, this was a positive trial with where the results were consistent across all subgroups, whether they were looking at age, sex, diabetes, layers of stent, and so on. So it really helped with having this device available in the United States. But, other trials have already looked at drug-coated balloons and really compared them against drug-eluting stents, not just plain angioplasty. And perhaps that's the limitation of the AGENT trial. The other trial that's also very, very important is in structural space, really, and it's the ALIGN-AR. And this is a lot of the times patients who have aortic regurgitation get off-label devices, which are the current TAVR valve platforms. But in the ALIGN-AR, they actually looked at the Trilute valve, which is designed specifically for aortic regurgitation, and it's meant to align with the native cusps and has locators which clip onto the native leaflets and conform to the annulus, allowing better alignment and deployment in the setting of aortic regurgitation. It's a single-arm prospective investigation device exemption study, and they looked at both safety and efficacy of the Jeddah valve Trilute system in patients with symptomatic severe aortic regurgitation and more high risk for surgical aortic valve replacement. They included, of course, patients who were symptomatic with at least grade 3 plus aortic regurgitation, and the heart team had to decide on referring these patients. Exclusion criteria were uni or bicuspid valves, or an aortic root that was more than 5 centimeters, and of course a previous prosthetic valve in the aortic position or concomitant coronary disease. Now, the primary safety endpoint was a composite of all-cause death, of stroke, life-threatening major bleeding, or vascular complications and acute kidney injury. And then primary efficacy endpoint was all-cause mortality at 12 months. Some of the key secondary endpoints included cardiovascular mortality, disabling stroke, hemodynamic valve performance and LV remodeling, as well as quality of life and NYHA functional class. So the comparator for primary safety endpoint was a performance goal, which was derived from contemporary high-risk TAVR cohorts reporting BARC2 composite endpoints, and this was set at 40.5. So they overall involved 180 patients. 177 of them underwent successful implantation. 50% were women, and the mean age was 75 years. 2/3 had an NYHA class of 3 and 4 with a mean SDS of about 4.1. The mean ejection fraction was 53.8%. The majority, 91% of the procedures were carried out under general anesthesia, and a large valve was implanted in over 57% of patients. But the procedural success was 92.8 with no procedural death, annual rupture, or coronary obstruction. So those are the most concerning potential complications. Valve embolization did occur in 4 cases. One ascending aorta dissection occurred. The primary safety endpoint at 30 days was 26.7%, meeting the non-inferiority criteria for the primary endpoint with the pre-specified performance goal. At the primary efficacy endpoint, of all-cause mortality occurred in 7.8% of the cohort at 1 year, again, meeting the non-inferiority criteria for the primary efficacy endpoint. Important to note that this is really a first iteration of the device, and operators are still in the learning curve, and so is the heart team in terms of imaging and size and so on for aortic regurgitation. Secondary endpoints like pacemaker implantation were reduced in the trial, 30% in the first 60 patients, and then 14% in the next 60 patients. And so it kind of shows you that the learning curve does change in terms of implantation depth and so on. In quality of life, there was also a significant improvement in the surveys that were taken. Now, the next thing is looking at important trials that were done for low-risk TAVR. And because these are low-risk patients, it's important to get longer-term outcomes. The preliminary data that had come out from Partner 3 was 1-year outcomes, but now the 5-year outcomes were reported. Just as a reminder, Partner 3 was a multi-center randomized trial. Randomization was 1-to-1 comparing TAVR using this balloon expandable platform of SAPIEN 3 against TAVR in patients who had severe symptomatic aortic stenosis and were at low risk, i.e. the STS score was less than 4%, and they had suitable anatomy. The primary endpoint was a non-hierarchical composite of death for any cause, stroke, rehospitalization, and secondary endpoints, again, a hierarchical composite of death for any cause, disabling stroke, non-disabling stroke, and rehospitalization. So at 5 years, follow-up was reached in 94.6% of those undergoing TAVR and 88% of those undergoing SAVR, perhaps prompting us to understand why these patients are lost to follow-up in the surgical arm. The primary endpoint showed similar rates in both groups, 22.8 to TAVR and 27.2 in the surgical arm. And the secondary primary endpoint using the WIN method showed a total score of 22.1 for TAVI and 19% for SAVR. So the mortality at 5 years was 10.2% versus 9% in TAVI versus surgery. Numerically, the study reported 5 years, at 5 years, 48 deaths in the TAVI group versus 34 in the surgical group. So numerically higher. But there's no difference in pacemakers and other parameters like stroke and so on. And from an echocardiogram point of view, which was also reported at TCT and simultaneously published, we see that the aortic valve gradient at 5 years was 12.8 in TAVR and 11.7 in the SAVR group. There was really no difference in the primary endpoint in terms of valve size and valve hemodynamics and deterioration. It was not really significant. Nevertheless, it is important to consider the TAVI choice in these patients, particularly that the mean age is actually pretty young in this population. I think it is important to interpret this trial in the context of the EVOLUT Low-Risk, where they reported the 4-year results with the self-expanding valve, again at TCT, and they looked at 1,414 patients. The mean age here was 74, and mean STS was 2 for TAVI and 1.9 for SAVR. 94% of the patients, again, in the TAVI group were available for follow-up and 89% in the SAVR group. And here it indicated that there was a continuing trend towards lower combined rates of all-cause mortality and disabling stroke with TAVR compared with surgical aortic valve replacement, and an absolute difference between the groups rose from 1.8 in favor of TAVR at 2 years to 3.4 at 4 years, demonstrating a very sustained benefit of transcatheter intervention for severe aortic stenosis. And so we wonder if the heart team really should be adopting a less conservative strategy in favor of TAVI, particularly in young, low-risk patients. But I think we still need 10-year outcomes because, as I mentioned, this cohort was young, 74 years of age. So it is important that all factors considered in terms of anatomy and the totality of evidence, probably we do need to be a little more selective. And finally, I want to end with an interesting trial, the TRISCEND trial, which looked at tricuspid regurgitation. Now, unfortunately, even in 2023, we don't have good options for transcath or tricuspid valve regurgitation. The surgical repair and replacement is not very durable. The current transcatheter repair options in terms of clipping have also not been very impressive. And so the TRISCEND 2 trial, we looked at 400 patients. And, the first 150 patients were randomized and reported in this trial. Mean age was 79 years, nearly 80% were women. The mean STS score, where they used the risk estimate for mitral valve surgery in the absence of tricuspid regurgitation, was roughly 10%. And all patients actually had AFib at baseline, and about 35 to 40% had a pacemaker or a defibrillator implanted, which is really important because that means you can still implant a transcatheter valve with pre-existing leads across the tricuspid valve. More than 77% of patients had undergone replacement, had secondary tricuspid regurgitation. So the EVOLUT optimal medical therapy arm, 43.8% had severe TR at baseline, 21.9% had massive TR, and torrential was about 34%. And in the optimal medical therapy alone, severe, massive, and torrential represented about 40%, 27%, and 31% respectively. Procedural success was actually reasonable. Again, given that this was the first iteration of the device and implanters were in their early learning curve, there were a couple of embolizations in this cohort and perhaps an RP perforation as well. Some required surgical intervention. At 30 days, the primary composite safety endpoint occurred in 27.4% of the 95 patients treated with the EVOLUT valve. And so a rate compared favorably with the historic safety data of tricuspid valve surgery at 43.8%. Severe bleeding was 10.5%. The need for permanent pacemaker was 14.7%. And as I mentioned, there was one, actually I haven't mentioned it yet, there was a single case of device-related pulmonary embolism, and cardiovascular mortality was 3.2%. So at 6 months, there was a significant reduction in the tricuspid regurgitation. 98% of the 8% of the patients had a moderate or less tricuspid regurgitation. 78% had none to trace, and with medical therapy, it was just 21.6% had moderate or less, and 50% continue to have massive or torrential regurgitation. In terms of quality of life, so the NYHA and the Kansas City Cardiomyopathy Questionnaire and 6-minute walk were superior with the transcatheter tricuspid valve replacement compared with the optimal medical therapy. So it is promising. Perhaps this is the first iteration. We're hoping that implantation technique and device refinements will improve these numbers, particularly in terms of acute procedural success. So thank you for hanging on here and listening to these important trials, and I hope it was beneficial for you.